Hi, this is Dr. Poole, and this topic is Hodgkin lymphoma. And I'd like to tip my hat to my colleagues, Ira Miller and Nicholas Ward in the Department of Pathology, again, hematopathologists who helped put this presentation together. Hodgkin lymphoma, formerly called Hodgkin's disease, arises from germinal center or post-germinal center B cells. It has a unique cellular composition containing a minority of neoplastic cells, which we call Reed-Sternberg cells and its variants, in an inflammatory background. It's separated from other B-cell lymphomas based on its unique clinical pathologic features and can be divided further into two major subgroups based upon the appearance and immunophenotype of the tumor cells. These two major subgroups are classical and nodular lymphocyte predominant. I just want to provide a little historical background to Hodgkin lymphoma. It was discovered by Thomas Hodgkin, who gave his name to Hodgkin disease. And he was a lecturer in morbid anatomy, as pathology was known back in the 1800s. And he also was the curator of a medical museum at the new Guy's Hospital Medical School in London in 1826. And it was during this period from 1825 to 1837 approximately that he made the contributions that are most associated with him, including the development of an anatomic museum, the development of the specialty of pathologic anatomy, the description of Hodgkin's disease, and the first application of medical problems to improved microscope of Joseph Jackson Lister, who was the father, by the way, of Joseph Lister, who initiated the concept of anesthesia. And what Thomas Hodgkin did was recognize through clinical histories and postmortem findings of 7 patients who had enlarged lymph nodes and spleen, but without inflammation or other significant pathologic findings. He did recognize that tuberculosis coexisted in some of the patients, but the firmness and size of the nodes and nodules in the spleen made him conclude that these findings were different, and so he recognized this disorder grossly. He also pointed out the disease spread to contiguous lymph node groups in an orderly manner, and that splenic involvement was a late development of this lymphoma that was attached to his name. Now, later on, in 1926, Herbert Fox confirmed microscopically that 2 of Hodgkin's original 3 patients included in his first report on morbid anatomies of the absorbent glands and spleens did not actually have Hodgkin lymphoma. One patient actually was found to have what we now know as non-Hodgkin lymphoma. Thus, Hodgkin's name is associated with both categories of malignant lymphoma. By the way, Hodgkin went on after Guy's Hospital. His relationship ended with this hospital because actually his non-medical concerns about the social welfare of Eskimos and Native Americans who were affected by the fur trade of the Hudson Bay Company in Canada. And so he went on after this portion of his career to devote himself to social and medical concerns, which concerned the plight of natives in all countries and how they were treated by Western civilization. Okay, thanks for permitting me that little aside. Let's talk about the epidemiology of Hodgkin lymphoma. The incidence has increased in a number of different settings associated with immunodeficiency, including solid organ or hematopoietic stem cell transplantation, therapy with immunosuppressive drugs, and in particular, HIV infection. There's an estimated 8,500 new cases from 2018. It's only about 10% of all lymphomas and less than 1% of all new cancer cases. Because of somewhat of its indolent nature and also improved treatment, there's about an 87% 5-year survival. Okay, what makes classical Hodgkin lymphoma different from all other lymphomas? First of all, as noted by Thomas Hodgkin himself, the orderly pattern of spread. So there's almost always a presentation as lymphadenopathy or an anterior mediastinal mass, which then spreads to the spleen, followed by the bone marrow, and then late liver and lungs. And the prognosis is directly correlated with the stage or extent of disease. Second is the histologic features. The malignant cells are usually a minority of the cell population, which is somewhat counterintuitive to other neoplastic diseases. And finally, there's the unique immunophenotype. The Hodgkin cells are positive for CD30, CD15, and are negative for the leukocyte common antigen CD45. Another feature is the association with Epstein-Barr virus, which may be either positive or negative. The majority of patients with classic Hodgkin lymphoma present with overt disease, most often seen as an asymptomatic enlargement of lymph nodes or a mass seen on chest film. However, the presenting symptoms and signs may be relatively nonspecific and more compatible with infection than malignant disease. The involved lymph node is usually non-tender with a rubbery consistency. The most common site of involvement are the cervical nodes in the neck, as 60 to 80% of patients have enlarged cervical and or supraclavicular lymph nodes. Enlarged nodes are found in the axilla in 10 to 20% of patients, and inguinal node involvement in about 6 to 12%. A second common presentation is the discovery of a mediastinal mass on routine chest film, usually done for some other reason. The mass may be fairly large without producing local symptoms. A significant proportion of patients with Hodgkin lymphoma develop so-called systemic B symptoms prior to the discovery of lymphadenopathy. B symptoms are present, however, in less than 20% of patients with stage 1 or stage 2 Hodgkin lymphoma, but up to 50% in patients with more advanced disease. So the classic high-yield histologic finding in Hodgkin lymphoma is the Rheen-Sternberg cell. These are large cells. You can see the size of the cell on the arrow, and adjacent small mature lymphocytes in the background for comparison. And you can see that this cell is roughly 4 to 5 times the size of normal lymphocytes. So these are large cells that measure up to 45 micrometers in diameter. They also are distinctive by having multiple nuclei or a single nucleus with multiple nuclear lobes, and each lobe or each nucleus has a large viral inclusion like nucleolus, and so the arrow is pointing to a bilobed or binucleate cell, and you can see the large nucleoli within each of the nuclei. Historically, Rheen-Sternberg cells were somewhat enigmatic and difficult to study because they often comprise less than 1% of the cells in the involved tissue. The central pathogenic issues in Hodgkin lymphoma are: what are the origin of these Rheen-Sternberg cells? What's the events that underlie the transformation of these cells? And what are the nature of the signals that produce the characteristic intense tissue response that actually comprises most of the tumor? Also important are a number of Rheen-Sternberg cell variants. The mononuclear variant is actually a large cell, but it just has a single nucleus, again, however, with the large inclusion like nucleolus. There are lacunar cells, which are delicate, folded, multilobated nuclei with abundant cytoplasm that appears artifactually disrupted during routine slide preparation and leaves the impression that the nucleus is just sitting in an empty space. And this is in particular associated with the nodular sclerosis subtype. And finally, there's the characteristic lymphohistiocytic or LNH cells. These are polyploid multilobated nuclei resembling a popcorn kernel. They have inconspicuous nucleoli in contrast to the other Reed-Sternberg variants, and moderately abundant cytoplasm. And this is important because it's characteristic for the lymphocyte predominance type. So the high-yield information that you need to know are lacunar cells associated with nodular sclerosis subtype and LNH cells associated with the lymphocyte predominant type. So among Hodgkin lymphoma, there are two main subtypes, so-called classical and the nodular lymphocyte predominant type. In the classical type, the tumor cells in this group are derived from germinal center or post-germinal center B cells, but typically fail to express many of the genes and gene products that define normal B cells. Based on differences in the appearance of the cells and the composition of the reactive background, the classic type is further divided into the following subtypes: nodular sclerosis classic Hodgkin lymphoma, mixed cellularity classic Hodgkin lymphoma, lymphocyte-rich classic Hodgkin lymphoma, and lymphocyte-depleted classic Hodgkin lymphoma. In the nodular lymphocyte predominant type, the Reed-Sternberg cells in this subtype retain the immunophenotypic features of germinal center B cells. In other words, they express the immunophenotype indicating that these are indeed B cells. In the nodular sclerosis type of classic Hodgkin lymphoma, the patients are usually young adults, and the majority have asymptomatic disease above the diaphragm, especially the cervical lymph nodes, as well as mediastinal involvement. The morphologic hallmarks of this subtype are the majority of Reed-Sternberg cells are the lacunar cell variant, as mentioned before, and diagnostic Reed-Sternberg cells are relatively rare. Also important is the nodular growth pattern, with nodules separated by dense bands of collagen, a mixed infiltrate in the background, and mummified cells. This subtype is rarely associated with EBV infection. So this is the cut surface of an involved lymph node, which shows a classic gross appearance. You can see these nodules of white tan tissue, and they're separated by slightly depressed gray areas here, which represents the bands of dense collagenous fibrosis, giving it the name nodular sclerosis. And this correlates with what we see microscopically. Here on the left, a low power view, we see these discrete nodules that are separated by bands of all this pink collagen deposition. So it correlates nicely with what we see grossly. And then on higher power, we see an example of these lacunar cells. So notice that these cells look like they're sitting in an empty space. And the nuclei, however, maybe look like just one nucleus, like here, or two nuclei, such as here. But notice that in each of these cells there are these prominent viral inclusion-like nucleoli. So this is what is meant by the lacunar cells, and remember that's associated with the nodular sclerosis form. The mixed cellularity subtype of classic Hodgkin lymphoma is a more heterogeneous category of classic Hodgkin lymphoma, which may have a diffuse or vaguely nodular growth pattern without the band-forming collagenous sclerosis. You can see fine interstitial fibrosis, but not to the extent as in nodular sclerosis. Classic diagnostic Reed-Sternberg cells in this variant are more easily identified compared to the NS type. The background infiltrate is also similarly variable, but typically consists of a mixture of eosinophils, neutrophils, macrophages, and plasma cells. Another distinctive thing about this variant is its frequent association with Epstein-Barr virus. So in the mixed cellularity type, again on the left, this is a low-power view. There's a somewhat vaguely nodular appearance, but mostly it's a diffuse infiltrate. And on high power, examination that we see on the right, you can see the classic Reed-Sternberg cell, and at the bottom, the so-called mononuclear variant. The lymphocyte-rich variant of classic Hodgkin lymphoma most commonly has a nodular growth pattern, but it may also be diffuse. Diagnostic Reed-Sternberg cells are present, and there may be mononuclear Hodgkin cells, and sometimes cells even resembling LNH cells. What's distinctive is the background, which consists predominantly of lymphocytes with rare or no eosinophils or neutrophils, in contrast to the mixed cellularity type. The lymphocyte-depleted subtype is sort of the negative of the lymphocyte-rich type. It also has a diffuse growth pattern and often appears hypocellular due to the presence of extensive fibrosis, necrosis, and a paucity of accompanying inflammatory cells. In this variant, there's a large number of diagnostic Reed-Sternberg cells, and you can find bizarre, weird variants of these Reed-Sternberg cells. About 5% of patients diagnosed with Hodgkin lymphoma actually have the nodular lymphocyte predominance type. About 75% of patients with this type are male, and there's a distinctive age distribution. There's one peak in children and one in adults, with the latter median age of about 30 to 40 years. Lymphadenopathy is the overriding clinical feature in this form. NLPHL tends to present as a chronic asymptomatic lymphadenopathy involving peripheral lymph nodes either above or below the diaphragm rather than central nodal sites. Also, B symptoms are rare in this variant, and splenic, hepatic, bone marrow, and extranodal involvement is uncommon with this variant. A key morphological feature of nodular lymphocyte predominant Hodgkin lymphoma is the presence of an atypical variant of the Reed-Sternberg cell known as the lymphohistiocytic LNH cell or LNH variant. These cells have vesicular polylobulated nuclei and distinct but small and usually peripheral nucleoli without the perinucleolar halos that you see in classic Reed-Sternberg cells. The term popcorn cell is sometimes used for these cells because the nucleus resembles an exploded popcorn kernel. This variant is also characterized by these LNH cells and a background of small B lymphocytes, follicular dendritic cells, and follicular T suppressor cells, which often form rosettes around the LNH cells. A distinctly nodular architecture is seen in a majority of cases, but there is not bands of collagenous fibers between these nodules like in nodular sclerosis variant. The immunophenotype of malignant LNH cells is also different than that of classic Reed-Sternberg cells that we see in the classical form of Hodgkin lymphoma. Again, the neoplastic cells in the classical form are typically CD15 positive, CD30 positive, and CD45 negative, and also negative for the B cell marker CD20. In contrast, the LNH cells are CD45 positive, CD20 positive, and also positive for a variety of other B cell antigens, including CD19, CD22, CD79A, and these are CD15 negative and only rarely express CD30, so very distinctively different immunophenotype. These cells therefore express B cell surface antigens like CD19 and CD20, as well as germinal center B cell specific transcription factor BCL6. So again, just to highlight the morphology, you can see these distinctive nodules. There's a complete one and here's a partial one at the bottom of the screen. And on high power examination, these are the distinctive LNH cells. Notice that these cells are peculiarly folded. This one is the closest thing, looking like a popcorn cell. And again, they have, instead of a single distinct centrally located viral inclusion-like nucleolus, these often have multiple smaller nucleoli, as particularly seen in this cell here. There's at least 3 small nucleoli. So that's what distinguishes them as a major variant of the classical Reed-Sternberg cells. So let's summarize Hodgkin lymphoma. This is an unusual tumor, approximately 10% of all lymphomas, consisting of rare malignant cells called Reed-Sternberg cells and their variants, and the tumors mostly consist of reactive inflammatory cells. We discussed 2 broad types, classical, which has several subtypes, and lymphocyte predominant, and these are distinguished based on morphologic and immunophenotypic grounds. The Reed-Sternberg cells of classic Hodgkin lymphoma make multiple cytokines and chemokines that influence the host response, which in turn make factors that support the growth of tumor cells. Classical forms are frequently associated with mutations that activate transcription factor NFKB with EBV infection, especially seen in the mixed cellularity type. LNH cells and the nodular lymphocyte predominant type, the growth and survival depends on immunoglobulin receptor signaling, which correlates with their expression of germinal center B cell antigens. And again, the lymphocyte predominant type expresses B cell and germinal center B cell markers, and it's not associated with EBV.